Allah, the most kind and merciful. I have to discuss the role of ultrasound evaluations of the disease of the renal system, adrenals and the spleens. We all know that renal architecture is a complex, and as we can see, the outermost boundary is the echogenic capsule. Then next to it is the hypoechoic cortex. Right. And the triangular anechoic area is the renal pyramids, and then is the renal sinus, which is a complex substance made of many things. We will discuss just the renal parenchyma, the cortex, and the medullary pyramids. They are labeled as the renal parenchyma. Renal cortex is between the capsule and the pyramids, and that constitutes the glomeruli, and glomeruli being the powerful reflectors that appears bright. Cortical thickness we measure from the capsule to the base of the triangular shaped pyramids, and thickness is important, and it is variable in the various ages. With advancing age it gets decreased. Below 30 years it is 2 centimeter, and as age advances above 50 it becomes 1 centimeter in thickness. Then cortical echogenicity, whether it is bright or less bright, that is also important, and depending upon the echogenicity we divide the cortical echogenicity into 3 grades. Grade 0 is the normal, where the cortex is hypoechoic than the adjacent liver, or on right side than spleen on the left side. So this is the grade 0 normal, that is the cortex of the renal cortex is hypoechoic than the liver parenchyma. Grade 1, when it is isoechoic to the liver or spleen, that is the grade 1, and when it is more echogenic than the adjacent liver tissue, that is the grade 2, and when it is brighter and there is loss of corticomedullary differentiations, or it is isoechoic to the renal sinus, the central part, that is the grade 3 cortical echogenicity. The central renal sinus, that is composed of the fibrofatty tissue, collecting system, renal vessels, and the renal lymphatics, and at Doppler we can see the various vessels within the renal sinus. The renal collecting system, that is made of minor calyces, major calyces, and the renal pelvis. The minor calyces, they are 7 approximately, 3 in the upper and 2 each in the middle and the lower segment of the kidney. And this is the minor calyces, then come the infundibulum, and this is the renal pelvis. This is the regarding the renal architectures. The renal hilum is the vertical slit on the medial aspect of the kidney, and the artery and the vein and the ureter courses through this renal hilums into or outside. And we can see on the Doppler, you can see here the renal vein, renal artery, and the ureter is normally not visible routinely. It is visible only when there is obstruction distally and it gets dilated. We can see the ureter exiting from the medial aspect of the kidney. The commonest finding in the renal system, they are the stones, which we can see with proper evaluations, and stones of more than 5 millimeters when they are visible as an echogenic focus with shadowing behind. And if they are small, less than 5 millimeters, such stones should be more echogenic than the adjacent renal sinuses. They may not produce the shadowing behind, but they are more echogenic. They are placed within the pelvic lisal system, and if such calcified focus is there in the cortex, that is not labeled as the stone, that is the renal cortical calcification, as you can see here. So an echogenic focus to label as a stone which does not produce shadow, that should be within the pelvic lisal system, that should be more bright than the adjacent renal sinus, and it should be reproducible, of course. If there are multiple echogenic surfaces with one shadowing behind, that is most likely a staghorn stone. And sometimes there is increased echogenicity of the renal pyramids, and that is medullary nephrocalcinosis, not the stone. And this is due to the hypercalcemia secondary to hyperparathyroidism. As you can see, multiple echogenic foci within the renal pyramid. This is the nephrocalcinosis. The ureteric stone, they are seen as an echogenic focus within the ureters, and there are three sites where we can see the ureter. One is just past the uretero-pelvic junctions, then at the site where ureter crosses the iliac vessels, and at the distal end of the ureteric orifice. This is just past the pelvic ureteric junction, a bright stone with shadowing behind within the ureter. And here is the stone at the site where it crosses the iliac vessel. These are the iliac artery and the vein, and this is the stone within the ureter. Then at the distal end of the stone, there are two stones that is producing the hydronephrosis. When the stone is at the distal end, patient feels severe pain, and that pain sometimes mimics the acute appendicitis, and we have also to rule out the cystic lesions in the adnexa if it is a female patient. The appendix at ultrasound that appears as a blind-ended, non-compressible aperistaltic structures, and the measurements we have to take on, the AP diameter should be more than 7 millimeter and the wall thickness should be more than 2 millimeter to label that gut part as a acute appendicitis. Of course, there should be clinical history of the pain and tenderness in the right iliac fossa. As you can see here, this is thickness of the wall is 3.5 millimeter. So this should be kept in mind that we have to see for the acute appendicitis as well. And in female patient, cystic lesion in the adnexal region, that will also produce the pain on the lower abdomen. Then bladder stone, they also appear as an echogenic focus with shadowing behind, and the stones may be small or sometimes so much large that is 8 to centimeter stone we can see within the urinary bladders. The stone in the urethra, we can see both on the transabdominal ultrasound as well as with the transperineal. As you can see here, this is the male patient. The stone is there in the prostatic urethra, and we can see also by the transperineal approach the stone within the prostatic urethra. Likewise, if there is sometimes stones is there in the distal end of the penile urethra, that we can see with the high frequency linear probes. Hydronephrosis is the aseptic dilatation of the pelvic lisal system, and it is always associated with some distal obstruction. That obstruction most of the time is due to stone, but that obstruction may be due to some mass within the ureter and sometimes mass compressing outside the ureter. As you can see here in the retroperitoneal fibrosis, which is the fibrosis of the retroperitoneum enwrapping the aorta as well as the ureter, and thus producing the hydronephrosis. There are various grades of the hydronephrosis, and grade 1 is just this slight dilatation of the pelvis only, and we see just the fullness of the pelvis. Grade 2 is the dilatation of the pelvis and the major calyces. This is the grade 2, which is the dilatation of the pelvis and major calyces, and grade 3 is the dilatation of the pelvis, major and minor calyces, and this is marked, but there is no cortical thinning. When there is cortical thinning associated, this is grade 4, that is called the grade 4. There is hydronephrosis, dilatation of the ureter, pelvis, major, minor calyces, and cortex has thinned out, so this is the grade 4. So there are 4 grades of the hydronephrosis. If we label, this is again the grade 4 hydronephrosis. And if we say it as the degree, grade 1 is mild degree of hydronephrosis, grade 2 and 3 is labeled as moderate, and grade 4 is the marked or severe hydronephrosis. Pyonephrosis is the septic dilatation, that is infection plus obstruction. At ultrasound we will see the hydronephrosis, but there will be pus within the dilated pelvis and calyces. Echogenic debris will be seen. Now you can see here the stones producing the hydronephrosis, and the anechoic area have debris inside, so it is the pyonephrosis. The focal defects of the kidney may be the cystic or solid lesions. The cystic lesions, as doctor mentioned, we see the anechoic area with posterior enhancement, whereas solid mass will show Doppler flow on the Doppler and we can differentiate between the cystic and solid lesion. The cysts may be the simple most of the times, arising either from the ductal dilatations, which are the renal cortical cysts, or maybe due to the lymphatic dilatation, which are the calyceal cysts, as you can see here in these pictures. And if the cyst have debris inside and patient is suffering from high-grade fever and localized tenderness, that will be the abscess within the kidney. The solid renal masses, they are also seen, and whenever we see the solid renal mass, that is supposed to be a malignant unless proved otherwise. And whenever you see the solid mass within the kidney, you have to see the contralateral kidney, renal vein and IVC to rule out mets there in the liver, and the para-aortic lymph node has also to be seen. The benign lesion within the kidney, that is commonest one, is the angiomyolipoma, which looks bright and well demarcated. As you can see, sometimes malignant masses may be bright, but they will have cystic component inside. So well demarcated hyperechoic lesion, if is visible within the cortex, that is mostly angiomyolipoma. And renal cell carcinoma is the malignant lesion. Most of the time it is hypoechoic or of mixed echogenicity, but sometimes it may be bright, and whenever the bright malignant tumor is there, that will have cystic area inside. As you can see, this is the angiomyolipoma, well demarcated bright lesion, but this bright lesion have cystic areas as well as vascularity on Doppler, so this is most likely a malignant lesions. The bladder tumors, they are seen as masses with irregular margins within the bladder, and they may be small or sometimes infiltrating the whole of the urinary bladder, and so producing the bladder outlet obstruction as well. Prostate in males, we can see both with the endorectal as well as the transabdominal ultrasound examinations. We have to see whether the prostate is of normal size or it is enlarged. Prostatic hyperplasia is labeled when the weight of the prostate is more than 25 grams, the post-wide residual urine volume is more than 100 ml, and the walls of the bladder, they are thick and corrugated due to the outflow obstruction because of the muscular hypertrophy. How we take the weight of the prostate? We take two measurements. This is the transverse section where we take the width of the prostate. This is the sagittal section where we take, this is the supra-inferior dimension, this is the anteroposterior dimension. We take the measurements in centimeter. A into B into C into 0.55 is the weight of the prostate. Normal is 25 grams. More than that is the prostatic hyperplasia. Whether it is benign or malignant, we can't see on the routine transabdominal ultrasound examination. That we have to evaluate further. The post-wide residual urine volume is also calculated in two sections. This is the transverse section, we take the width, and this is the longitudinal sections, and we calculate the weight of the post-wide urine volume, A into B into C into 0.5, and which significant is more than 100 ml. The corrugated and thick wall due to the outlet obstruction can be seen, and sometimes stones with prostatic hyperplasia are as well visible, and sometimes there is the diverticuli formations, that the outpocketing from the walls of the urinary bladder, and diverticulum may also have the stones inside, as you can see here in this picture. So this is regarding the renal systems. Spleen is an intraperitoneal organ lying between the greater curvature of stomach medially and the left hemidiaphragm superiorly and the left kidney inferiorly. And we have to measure the spleen whether it is normal or enlarged. For that we take two measurements mostly: pole to pole length, which is 12 centimeter normally, then thickness is 3 to 4 centimeter, and sometimes we calculate the splenic index, which is the product of the length and the thickness of the spleen, and normally it is 45 in adults. This is the spleen. How we measure this: the length of spleen from its superior to the inferior edge, and from hilum to the outer convexity is the thickness of the spleen. We measure these in centimeter and multiply to calculate the splenic index. This is an enlarged spleen. The length is 21 centimeter. Normally is just 12 centimeter. Accessory spleen is presence of isoechoic area close to the spleen, and we have to differentiate it from the hilar lymph adenopathy. Commonest abnormality is the enlarged spleen. Then in cases of the roadside accident, due to trauma, splenic rupture may be there, and we have to see whenever there is trauma and patient comes for the splenic evaluation, we have to see whether the capsule is intact or capsule is ruptured. If the capsule is intact, there will be the intraparenchymal bleed or hematoma, as you can see here, and if the capsule is ruptured, there will be the perisplenic hematomas. So, in case of roadside accident, which involves the left half of the abdomen, we have to see whether the splenic rupture is there or not. Capsule is either intact or it is abnormal. Then, focal defect of the spleens may be the simple cyst, it may be hydrated cyst, as Dr. Sabha has already told you. Within the liver we can see hydrated cyst, within the spleen we can see the hydrated cyst. Multiloculated cystic area most likely is the hydrated cyst. Abscess can also be visible. Cystic area with debris inside is an abscess, and of course patient is suffering from local tenderness and high grade fever as well. Then mets within the spleen may be from the melanoma, leukemia or lymphoma, and we see the multiple hypoechoic masses within the spleen, and most likely these are the mets. And the last is the adrenals, suprarenal gland. They are the paired organs lying anteromedial to the upper part of the kidney, and this is difficult to visualize at ultrasound, but with proper techniques we can see on both sides, and each gland has a body and two limbs. One is the lateral and the medial limbs, and as you can see here in the neonates, it is easily visible. On the right side is V-shaped, whereas on the left side is Y-shaped adrenal gland, and the adrenals outermost hypoechoic area is the cortex, and the inner bright area is the medulla of the adrenal glands. And on the right side, it is seen between the IVC and the right crus of the diaphragm at ultrasounds, and probe is placed in transverse section when the patient is in left lateral decubitus positions. And on the left side, it is visible between the spleen, left kidney, and the aorta. This is the left adrenal gland. So this can be seen at ultrasound examinations. The cystic lesions as simple cyst with enhancement, and that cyst may be hemorrhagic or infected. As you can see here, this is the cyst with debris insides. This is the adrenal cyst with hemorrhage insides, and sometimes solid masses can be seen in the adrenal gland, which may be adenomas or adenomas, or sometimes malignant lesions can also be visible, which appear as hypoechoic areas, and this is most likely pheochromocytoma. And with that, thank you very much.